Welcome to the Speakeasy Health Podcast, where we speak about hormone health topics in an easy way. Today I'm joined by Dr. Naomi Whittaker, who is the founder of RRM Academy and is an OBGYN fertility surgeon focused on women restorative reproductive medicine, compassionate healthcare, and education. Dr. Whittaker is a board-certified OBGYN and a fellowship-trained surgeon who specializes in the Creighton Model Fertility Care System and NaPro technology. Dr. Whittaker helps women improve their gynecological health and avoid or achieve pregnancy in accordance with their natural fertility using the latest research, medicine, and surgery. Today we will dive into questions on endometriosis and PCOS, so if you suspect you suffer from either or you would like more help on how to navigate these conditions, grab a cup of tea and join us in this wonderful chat. Hi Naomi and welcome. Thank you for joining us on the Speakeasy Health podcast. I'm really excited to talk to you about the impact of PCOS and endometriosis on women worldwide. And we are so blessed to have you here, given that you specialized in the Creighton Model Fertility Care System, which is basically charting your cycle, looking for biomarkers such as basal body temperature and cervical mucus to confirm ovulation. Is that correct?
Yes.
That combined with the NaPro technology to treat the underlying cause of gynecological issues and infertility, such as endometriosis and PCOS. I think this talk is a very important one because we know that in the UK alone, and I don't know, you're from the US, right? I don't know the stats from the US, but I'm guessing on a larger scale. But in the UK alone, 1 in 10 women suffer from PCOS and 1.5 million women suffer from endometriosis. And I'd like to start by giving a simple definition for our audience in terms of what is PCOS and what is endometriosis and what are some of the signs that we should be on the lookout for when it comes to these conditions.
All right, which one do you want to start with? PCOS?
Yeah, let's start with PCOS.
All right, so what is it? PCOS is a condition, it's a syndrome, so it's a cluster of symptoms that go together. So it encompasses a wide variety of women. I think it actually encompasses probably multiple disorders in one, actually. But the thing that puts them together is that they're all related to elevated androgens of some sort. And so these elevated androgens can lead to other issues down the road, including irregular cycles, signs or symptoms of high androgens, which are basically a form of testosterone. And so that can include excess hair growth, and it can also lead to anovulation or accumulating multiple follicles on the ovaries that aren't turning into what it should. They should be developing into tiny actual cysts that hold eggs and release an ovulation. And so women need 2 of 3 criteria to meet the diagnosis of PCOS, including polycystic ovaries on ultrasound and or signs or symptoms of high androgens and or irregular cycles.
Can you tell us a bit about what is an ovulation? Because I know that's a medical term. A lot of people do know what it means, but for those of us that don't know what an ovulation means.
Yes, it's a lack of ovulation, which is the key hormonal event of the menstrual cycle. And so most women we see on the outside, we notice the menstrual blood, and we think that's the key event. And that is the beginning of the menstrual cycle. But really, what we want to happen as a sign of health is not the period. I mean, that is also important, but ovulation. And so that's releasing an egg every month around mid-cycle is generally when it occurs. Mm-hmm. And that's what our body is designed to do to help promote release of estrogen and progesterone, which are important for health and fertility purposes.
And estrogen and progesterone, you would say that they are the main cycle hormones that every woman should be having enough in proportion of in the first part of the cycle, more estrogen, in the second part of the cycle, more progesterone, which helps when we actually ovulate. Going back to the anovulation bit, we won't have enough progesterone in the second part of our cycle if we don't ovulate, right?
Correct.
And so PCOS is a cluster of symptoms. Let me see if I got that right to reiterate for our audience. It's a cluster of symptoms, and it shows with irregular cycles and hair growth. And hair growth can be on the chin, on the chest, on the face. I guess with high androgens, it comes acne, right?
Yeah, so it doesn't have to be excess hair growth, but that's one sign. Yeah, it could be acne, mainly typically on the jawline, especially for androgens. It can also go with, there are other metabolic issues that go with it as well, so it impacts the whole body. Hormones do. And so 70% of women with PCOS have insulin resistance, and that can worsen androgens as well. And so it becomes a vicious cycle. Higher insulin increases testosterone, and vice versa. And testosterone worsens insulin resistance. And so that can worsen over time when we aren't educated on what's happening with our bodies and how to manage it. And then that can lead to other health issues down the road, like cholesterol, diabetes, heart issues, weight gain. We also see thyroid disease and sleep apnea, for example. So it can lead to serious health issues. So it's really important to be on top, to be aware, to be educated, to be able to be proactive.
Absolutely, I agree. That's such a good way to describe the dangers of not only like PCOS is taken in whenever someone goes in and tries to understand if they have PCOS. As a female, they only are told, oh, don't worry, you don't have to ovulate until you want to have babies. But on the other hand, PCOS, as you just portrayed, it's an incredibly complex cluster of symptoms and a condition that can impact not just your ability to have a child, if that's what you wish, but down the line it can completely turn your metabolic health upside down, correct?
Right.
Thank you for that definition. I think that's very useful. Shall we try to understand a bit of the same when it comes to endometriosis?
Yes. They're two separate conditions, and there's a lot of confusion about both and misinformation, right? That's what's very common. But endometriosis, and they can go together, right? Some people say, oh, if you have PCOS, you can't have endometriosis. That's not true.
Oh, okay. That's interesting.
Yeah. Have you not heard that?
Yeah, I have. But I would like to know from your perspective, what's your take on that?
It's just related to poor knowledge and awareness. Someone blame everything. They get they're so excited to have a diagnosis, and they're convinced that's what they have, and they aren't aware of the complexities and the details of each issue. And so, for example, for PCOS, if they have pain, they say it must be my PCOS. But really, when we do that, PCOS doesn't typically directly cause pain. So if you're having pain, you should really consider something else going on, like a severe ovulation defect, which I do see, and then leading to large cysts. That's technically a separate issue than PCOS. PCOS should be stacking up little follicles, technically. It should be called polyfollicular ovarian syndrome, not polycystic, because they aren't true cysts. So someone who even defined the whole condition was wrong. I mean, if you want to really go back to like the basics, I mean, that's pretty bad. We should really update it. And I've had people on social media argue with me because they said, I have cysts. It's polycystic ovarian syndrome. Like, you don't know what you're talking about. I'm like, oh, gosh.
Hold on a second. I think I know a thing or two.
Like, oh my gosh, well, technically it's all wrong. The whole system is wrong. I don't know how I even describe that to you and have you believe me, because, I mean, women are so convinced of their one thing, and they're on guard too, right? Because there's so much gaslighting, and they've had to be that way to kind of survive. And so they get very, very defensive. So, but, you know, when there's severe pain, especially, or even mild, there should be some consideration in PCOS that something else is going on.
Is that where you would start looking at endometriosis, for example?
Yeah, so it depends, right? Like if they're having large cysts, it could be just related to, well, they are trying to ovulate, they're having an abnormal ovulation, and a lack of progesterone is preventing the cyst from resolving. So there can be related to the ovulation issue of PCOS, but technically that's not standard for PCOS. Does that make sense?
Yeah, totally. So what are the symptoms of endometriosis? What should we look out for, apart from we have this unexplained pain that it kind of like, not necessarily someone has PCOS, but they have this unexplained pain coming from out of nowhere, not just when they're on their cycle. Is this something that should tip them off when it comes to endometriosis, or is there something else?
Yeah, I mean, when there's pain, especially cyclical, endometriosis should be on the radar. And what is endometriosis? It's tissue similar to the lining of the uterus, somewhere outside of the uterus where it shouldn't be. And it can grow and spread similar to cancer, though it's not a cancer. And it causes a lot of inflammation and immune system dysfunction, but it's not technically an autoimmune disease. So it's kind of somewhere between cancer and autoimmune disease, but it's its own thing. And so, yeah.
That's that distinction. I never heard anyone provide that way of describing endometriosis, and I think it's very refreshing, because it's not something that you cannot deal with, but it can be difficult to diagnose and learn how to deal with, right?
Absolutely.
And you mentioned inflammation. I know that, and this is a question many of us are dying to actually know. Is there any truth behind an anti-inflammatory diet when it comes to endometriosis support? Because a lot of people actually find it helpful, but I guess the other side equally finds no distinction between having been on this diet for a few months versus having their usual diet that is not necessarily anti-inflammatory. What's your thoughts on that? And yeah, I'm just curious.
Yeah, so to truly understand endometriosis, you have to really take care of or talk to many women with endometriosis, because it's such a unique disease for every single woman. You can't really lump one treatment and say it's going to help everyone for endometriosis. But
I don't think that works with anything, right? Like doing this generalization method.
Yeah, but especially endometriosis, because these lesions can grow. For every single woman that comes to me for surgery, the lesions are in completely different spots. It's never two cases are ever even close to the same. And I can't predict it. I can't predict the stage before I go into it, really, or which organs it's on. I can't base her symptoms on the locations of the disease or the severity of the disease, right? Stage 1 can cause crippling pain. Stage 4 can cause no pain and just infertility, perhaps. So the same goes for treatments. Surgery, as far as tools that I have, has the highest success rate for managing symptoms and getting is the closest to a cure, that there is no cure. Then next, I would say pelvic floor physical therapy is one of the more common interventional ways that I see women feel better. Bioidentical progesterone. We often see very severe, hormone issues with PCOS or with endometriosis. I had a really interesting patient recently. Her estrogen was, I've never seen so high, and she's having frequent recurrence of endometriosis. So I don't know if she has a specific variation of endometriosis or if it's hormones or both together, but clearly her body is just really struggling in so many ways. And so testing hormones, potentially talking about diet. So that's a very unique conversation, and that's one of the hardest things I see. I try to do the big things. All right, do you have a disease? I mean, so it depends on the patient, but let's say by the time they come to me, because usually they've talked to my nurse practitioner and try to see their options and do conservative things. By the time they get to me, I like to get the disease out, potentially do physical therapy, bioidentical hormones, and then, okay, at that point, we know the disease is out. The trigger response, or the trigger of inflammation is out. You can do it in different ways, but at that point, when they see me, then okay, you're still having residual symptoms. Next, let's try gluten. That's the most common inflammatory trigger for pain. Sometimes dairy too, but I talk to them about their different options. Okay, you can go just gluten because it's the most high yield, or you could technically do more of an intense anti-inflammatory diet and reintroduce things slowly. You know, I don't like the extreme restriction because I think it's very burdensome emotionally, and so I try not to encourage that for most. Now, there are definitely cases where, let's say, they have horrible skin issues and, you know, GI symptoms all the time. You know, perhaps we might be more aggressive in those cases. But if it's the other day, someone said, okay, you know, I did all the things, we did surgery and I'm doing the hormone support, and I'm just still having this cramp like a week before. Mm-hmm. I really suggest just trying, you know, to eliminate gluten for 6 to 8 weeks and seeing if you can heal your gut and potentially reintroduce it later. Some stay off of it long term and feel better, and some are able to reintroduce it. But like, you're not going to really prove that in a standardized, you know, in a randomized controlled trial because it's very individualized.
Yeah, absolutely. I just feel some people might get a bit more lucky with the way their bodies respond. It's strictly speaking about the anti-inflammatory diet, whereas some others might just have worse lesions that have grown pretty much all over the place, and that doesn't really help. You mentioned physiotherapy, and are you referring to pelvic floor exercises? Could you mention the best one that you would say? And I know it's really hard to always narrow down to something, and I know things take time, but if someone were to start with one exercise and then build up to more later on, which would be the one that you could recommend that people start with?
I mean, I send them to a physical therapist to be able to feel the pelvic floor and know, is it too tight, for example, and which muscles and where's their, you know, weak points, and be able to feel and tell the woman specifically for her case. Does she need a wand? Does she need this? You know, so really I defer to the experts of the pelvic floor, which are the pelvic floor physical therapists for that. I shadowed them, and I was very humbled by the amount of knowledge they had about the pelvic floor. I was not trained in that, so I'm not a nutritionist. I'm not an expert in that. I kind of picked it up out of necessity, but I feel like that I'm not, you know, I'm not the best at nutrition. I'm not the best at the pelvic floor. But what I've seen is I really encourage women to go to at least one visit, get a personalized evaluation of the pelvic floor. You know, is there a problem? What's the severity? And is it tension? Is it, you know, what is it specifically? What's the severity of it? I just see such a variation in women for that. So I think the best, ideally, would be going to someone. And if it's expensive, maybe just going once and being honest with the provider and saying, hey, I'm here for a diagnosis, and could you give me some exercises to take home? Now, I imagine the pelvic floor is not something that your brain is used to controlling. So I think the best outcomes are when you're able to frequently go to that pelvic floor therapist. And they should really be feeling internally. And you should really feel confident about their knowledge, because not all are equal. Yeah. So they don't do an internal exam and they say, just do Kegels, here's a paper and exercises. That's just kind of throwing a birth control pill at you. Like, it's just not individualized care for what you need. No one can just say, oh, look at you and say, well, you need Kegels and that's it. That's, that's actually happened to me. So I was like, I go to pelvic floor, I'd send everyone, I better go. I got risk factors. So then I had the worst experience, and I was like, wow, I just wasted all that money.
Yeah, I imagine that happens to so many women, unfortunately. But, you know, this knowledge alone, I don't think many women understand that pelvic floor congestion, like restricted blood flow, can actually impact how endometriosis acts in someone's body, right? So I think just you sharing this with us, that please go see a specialist as well. If you feel like you've done everything, but you haven't done this, if you can afford to do so, go for multiple visits. Trust this person that's going to support you, like look at how things look internally. And then if you can do that, try to go at least once, do your research properly and find someone that many people trust and give good reviews about. Even if you can just go once, it might be helpful. So I think this is going to be extremely valuable for a lot of people that struggle with endometriosis.
Yeah, I think people appreciate that if you have back surgery, you need physical therapy for your back. Mm-hmm. People don't realize the pelvic floor is even more complex than the back. It has multiple layers of muscles, so that's holding up all these organs. So, I mean, imagine back surgery and then some if you're going through endometriosis. Even if you don't go through surgery, your pelvic floor is being challenged with chronic pain and tension. And some people hold their stress in their shoulders, and some people hold their stress and tension in their pelvic floor.
Yeah, I hear a lot of people, I like to call them, and I myself am a little bit like that. I'm like, love the woo-woo side of things a little bit. I think there's some knowledge in that. I feel a lot of people are saying trauma stored in the hips gets released with twerking. I don't know what you feel about that. I know it's fun, right?
I don't know if there's a study on that. That'd be interesting.
So yeah, but I'm very interested to understand a bit more about the concept of NaPro technology, because this is what you specialize in as well, and how can we use it to better treat PCOS and Endo. And correct me if I'm wrong, but from my research and since I started following you, I learned a little bit about it. It's basically treating it from the root cause, to put it very simplistic, right? Yep. Of course, there's more to it, but that's it, right?
It's good quality medicine. So if a woman is important to know what her cycles are doing, which is understanding when she's ovulating, then we can run tests specifically to her based on her cycle, and then give treatments based on her biomarkers and time it correctly. Mm-hmm. Right? And so that's kind of the start of it, right? Being able to time testing correctly, which is a huge issue with women's hormones because it's different on every single day of the cycle. You can't just pick cycle day 21 and assume things, or you won't get a proper diagnosis.
Well, before you share more on this, I would like you to tell us, when is the best time to test when it comes to your cycle hormones? If you were to test for estrogen, luteinizing hormone, follicle stimulating hormone, and progesterone, when would you test these hormones? Because the answer is definitely not in the same day, right?
Right. No, if you do it on the same day, then it's trash. Cycle day 21, trash. So it has to be very individualized. So, well, LH, FSH is pretty easy. Those are cycle day 3 or so. 3 to 5 would be okay. So really that's the report card of how, and you can do estrogen then, but that's not very useful in my opinion. But that's the report card of the brain ovary connection and how that's working. And that's when the ovaries are supposed to be quiet. So you're just kind of getting a baseline. You can get a baseline ultrasound to rule out cysts, because at that point you shouldn't really have cysts. You can have follicles less than 1 centimeter. But you really shouldn't have anything over 1 centimeter around cycle day 3. So that's a good quiet time when all the hormones should be at their lowest. So testing estrogen, progesterone, not super useful at that point, because they should be, well, progesterone should definitely be very, like almost 0. And estrogen should is not nearly at its peak, or where it's not at its, it's not really where where it matters most. Mm-hmm. So we truly know. So it depends on what you're looking for. So we'll check estrogen in a series around ovulation for women undergoing, issues with fertility, and we'll want to watch it rise and peak right before rupture of the follicle. And then after ovulation, we call it the last day of mucus peak day. And so we'll check peak plus 3, 5, 7, 9, and 11. And that's when we want to check estrogen and progesterone. We want to watch both of those curves rise and fall, and we want to see the levels and that ratio between the estrogen and progesterone.
And this is how you start with the NaPro technology, right? By understanding all these biomarkers and understanding where all the hormones are at the right time in a woman's cycle. Sorry?
Oh, so yeah, the Crane model system is the charting, is just understanding how to write your biomarkers, interpret them, And then the NaPro technology is the medical testing and treatment. So yes, if you start doing testing, you're going into NaPro technology.
All right. And when it comes to charting, what would you, if someone has PCOS and they don't really have a cycle, because we know with PCOS you can miss cycles like for 3, 4, 6 months. I have stories of people that haven't had a cycle for 8 months with PCOS after they got off the birth control pill. Of course, that's a bit more complicated. Is it the post-birth control or is it PCOS? But let's say that for someone that has PCOS and they don't have a cycle, can they use this charting model that you're talking about, and how would they use it?
Yeah, so I mean, sometimes when women don't have a period, they still have withdrawal bleeds or they still have mucus. And so learning about what the body is trying to do in between these 8 months is going to be helpful for testing and treatment. Then if we see that she's just having no mucus, no bleeding, nothing's happening, everything's kind of frozen. I compare it to a PCOS like that. I compare it to a frozen computer, right? Like nothing's really getting released, right? We're kind of stuck in that pre-ovulatory time, and the brain's trying to raise these signals to say, release the egg, but it's all kind of backwards. So that in of itself, being taught how to chart, we can teach anyone, no matter what her cycle is doing, about all the biomarkers and how to look for them and how to be confident that she didn't miss any biomarker. So once we confirm that, then we can run tests, or we can also just try to cause her to, promote a cycle with progesterone, typically high dose, to cause a vaginal bleed so that the estrogen isn't wreaking havoc. Because if estrogen is high that whole time, then we run into a lot of potential issues, including thickening of the lining of the uterus.
And do you think, and this is a really great segue in what I wanted to ask you next, do you think that estrogen dominance, which is way more estrogen than we're supposed to be having throughout our cycle, is that a component to developing endometriosis as people are pointing it to be?
Well, I would, we don't know, because we don't really know, but there definitely seems to be some hormonal worsening with endometriosis. It could be just symptoms or it could be disease, and it probably depends on the person. So I do think endometriosis is a condition that women are born with. And at the time when her hormones start rising around menarche, or when someone starts cycling, that's when the implants are really inflamed, related to that estrogen. So down the road, if she has repeated cycles of estrogen imbalance, so it's called unopposed estrogen, medical literature is what they say, and then they get really mad when they say estrogen dominance, but it's literally the same thing with just 2 different descriptors. But just like I just saw one yesterday, her estrogen was through the roof. Your estrogen after ovulation should not be over really 150, 180 units that we use. And hers was 420. I mean, and she's been coming back, really good endosurgeon. She came to, I didn't do her last surgery, but the person that did it, I trust. And she's doing these very aggressive endosurgeries now every 10 months or so. And her endometriomas have recurred, so it's at least causing inflammation. Endometriosis implants can feed themselves hormones too. So the serum is only one part of the picture, right? So that's not measuring what's actually happening in that ovarian environment, and what the implants are doing within themselves. So they can grow their own nerve fibers, they can feed themselves hormones similar to a cancer. So when women probably have extra in their body, and then let's say they have other dysfunction, as in constipation, which is super common, likely that's all accumulating and making everything worse. And her symptoms were absolutely horrible. So it's a component of that big complex picture of each individual person. Definitely progesterone is almost always deficient in these women. And that's just common with our society, probably with our stress, I assume, or diet. I'm not sure. But estrogen dominance is common in endo, but it's not a
prerequisite, basically.
No.
So we're basically born with this condition, with endometriosis, and it kind of takes root and starts impacting our lives as we get into puberty, and our hypothalamus and pituitary, which are two master endocrine glands, are starting to release these hormones to talk to our ovaries and start ovulating and so on. And as we go on, the endometrium gets thicker, can spread through the body, can cause lesions, can cause more and more pain. Is that correct? It's a fair summary?
Yeah. Typically that's how it can be. It's usually progressive. There are some women where their pain, they're like, it was really bad as a teenager, but it got better. We don't really understand why that happens, but one theory for those women is that nerves are damaged over time, and so they don't feel the pain as much as the disease grows deeper.
That's interesting. So are you saying that there's some women that with time, as endometriosis progresses, the nerves get damaged to the point that they don't feel the pain as bad as they used to feel it?
That's one theory, yes. Another theory is, as teenagers, I sure was eating pretty badly, right? We're eating mainly carbs, processed foods, not sleeping. So the opposite lifestyle that we should have to manage endometriosis. Plus, we never have boundaries. Like, we don't know how to protect our mental health as a teenager. Actually, our mental health is usually at its worst because of all the changes. And so all of those things are very specific triggers for endometriosis. So perhaps that's also worsening at that time. And as we mature and kind of slow down and get control of our lives and don't pull all-nighters regularly, that also is going to help. So probably there's some lifestyle component in maturing after that.
So what I hear you saying is that we should start educating young girls from a very young age, not just on the pill, which is something that is most talked about, but also on the downsides of, having the teenager lifestyle, nutrition-wise and lifestyle-wise, that someone has when they're young and getting into their puberty years. We should really start at that point, not 10, 15 years later when the pain is unbearable and the damage has been done.
Yeah, let's teach them what's abnormal. I had no idea. I suffered as a teenager terribly. And I look back and think, wow, like how I had daily migraines, for example. My family doctor didn't ask me anything about, is it cyclical? Do you have heavy bleeding? Do you have any? If he had just asked that, and I had acanthosis nigricans, which is the darkening pigment on your neck from insulin resistance, I asked him about it. He didn't even know what it was. It's just, all these signs were there had he just either known or lost, and so I look back and I think, and then, as a teenager, you don't realize how, if no one's helped you, it's not intuitive.
It's not possible.
Sleeping or, regularly and eating healthy. What is eating healthy? I didn't know. Everyone told us then cereal for breakfast was normal. So,
especially in the 90s and early 2000s, what was a healthy diet? As little carbs as possible and no fats. So that kind of healthy diet was definitely not a good way to start.
Everyone's adrenals and flared their endo for sure. So.
Well, I guess when we go through these things ourselves, it makes us. That's why I guess you're such a good doctor and such an open-minded doctor now, because you've been through this yourself, and it's very rare to see someone like yourself. So for the better or for the worse, I guess it brought you where you are now, and you can help so many women.
Yeah, I'm really happy for what I've been through because, I can use it for good. And I really feel like I can at least have a taste of what women have gone through.
It's more empathic in that way.
Yeah.
Yeah. So in terms of what tests would you recommend for people that struggle with symptoms of endo and PCOS but haven't yet been diagnosed? Because we both know it takes, on average 6 to 8 years for someone with endometriosis to get diagnosed, and PCOS with the Rotterdam criteria, which I guess Lara Bryden has just took an article out to say that she's not really agreeing with that criteria. I feel like she's saying it's not really an accurate way to diagnose someone with PCOS. There's definitely more complexities to what she was saying it, but I'm saying it in such a simplistic way. So it gets so confusing to actually know how to test, to diagnose, right? So what would you do in your opinion, in your professional opinion, test-wise?
Yeah, I mean, I would say first for endometriosis, I made a free 3-tier endometriosis symptom self-survey. So, because I really, in my practice, cycle charting and symptoms, that's where I get the diagnosis, really. And then I'll order a pelvic ultrasound, and even if it's normal, it doesn't usually change.
And this is for endometriosis, right?
Endometriosis, yeah.
Okay.
And so, it includes infertility, tail end brown bleeding, extreme fatigue, skin sensitivities, family history, what else? Radiating pain, needing to be in the fetal position, using a heating pad. Those are all very specific for endometriosis. And, what's really interesting is when I first screen women without my survey, I'll ask them about their cycles. And they're like, well, it's bad, but my friend, she vomits and passes out during her period, so mine's not that bad. They'll minimize their symptoms, and then I'll hand them the survey, and then they'll score really high. And I'm like, no, you are suffering more than you just explained to me. Women will belittle their symptoms when they come to me until I say, okay, no, fill out this survey. I'm going to give you a score. And when they do this scoring system, most of the time I'm surprised at how much higher it is than what they say. And so I think I have found that to be most useful. Plus, automatically women feel validated when they see these specific symptoms that seem very weird and no one's ever talked to me about them before. Okay, now you're linking them to other things. Things are starting to make sense. So one of the hardest parts of getting to surgery is not thinking you're crazy because your ultrasound's normal. Everyone's told you it's normal. Your mom told you it was normal. Your friends told you you're being a baby. Your doctors kept saying it's fine. You don't have X, Y, or Z. One symptom, which, there's a huge list really that you need to screen. So a lot of these women are like, I hope you find something. I hope I'm not crazy. They'll frequently just say things like that, like right before surgery. And I said the same thing before my surgery when I had endo surgery. So we're all guilty of it. I mean, that's just culturally, we've been molded to deny our pain or belittle our pain and our symptoms and live and push through it because we had to get through, to live a relatively normal quality of life, hopefully. That's a pretty accurate self-screen, and it's hard to say what number on the questionnaire raises or lowers a suspicion, but over 40, extremely high on that questionnaire, and over 10, I would say, really consider talking to someone that you trust about the diagnosis of endometriosis, but it can only be diagnosed with surgery.
I know that people are going to feel so validated when they listen to this part of the podcast. I don't have endometriosis, but I feel validated from a whole lot of different reasons. Just hearing someone saying, you're not crazy, is not in your head, please advocate for yourself, you don't deserve to suffer, you don't deserve to have a miserable quality of life. It can get better. You are worthy of getting yourself better and trying to get yourself better. So I guess the message from this bit of the podcast is don't let anyone tell you that if you're in pain, that's normal or that's in your head or that you're crazy.
Exactly.
And in terms of PCOS, what?
Yeah, so knowing the Rotterdam criteria, or what Laura Brydon's talking about, I don't know, but I'd love to be interested in that. But knowing, okay, persistent acne, irregular cycles, especially over 35 days. What else? Signs or symptoms of high blood sugar, like especially fatigue, easy weight gain, potentially even, loss of hair, hair thinning, male pattern, that darkening on the neck, or lots of skin tags, or the darkening can happen in the groin as well, or you can even have these boils that form in the armpits and in the groin too. So usually it's just this vague, sometimes fatigue. We see vitamin D deficiency. We see low energy, hypothyroidism go with it, easy weight gain, typically.
Hypothyroidism. Hypothyroidism is just for the clarification purposes, it's an underactive thyroid. Is that correct?
Correct. Yeah.
All right.
Yeah. Mm-hmm. So all of those, and again, they're different flavors of PCOS. So one is that easy weight gain, and then the skinny PCOS type, I feel like they tend to have more just the irregular cycles, totally unpredictable. And then there's that other variation of easy weight gain that may or may not have irregular cycles, but definitely more strong insulin resistant type.
And in terms of
high androgen symptoms.
Oh, that's really helpful to know. Thank you. In terms of blood tests, would you take some certain standard blood test that someone can say, okay, now I know what symptoms to look for, but what about blood tests that I can do? We know endo, it's only certain with surgery. We know the symptoms of PCOS, but would you test testosterone, for example? Would you test DHEA, which is perhaps another marker of showing us PCOS is there?
Yeah, so for diagnosis, cyclodec 3 to 5, LH, FSH, DHEAS, 17-hydroxyprogesterone, testosterone. What else? Anything else I'm missing? Those are the main ones to get an idea to screen, right? Trying to think. And obviously other ones I want to not miss if I'm thinking about like thyroid, vitamin D, cholesterol, insulin, ideally, or B1C. To see blood sugar issues.
And you mentioned it's in the beginning of day 1 to 3 of your cycle that you test
3 to 5 usually.
3 to 5.
Yeah.
But let's not confuse to how you test just for regular hormones, which is what you mentioned in the first part of the podcast.
Right.
So if you want to just test for your estrogen, progesterone, LH, and FSH, go 20 minutes behind and look for that indication. But if you want to test for PCOS, day 3 to 5 of the list of tests that Naomi just mentioned.
Yeah. And then another AMH is also, that's the only way it's sometimes useful is if you want to do a quick, easy screen AMH, if it's very high, like 5, 7, 10, the higher it is, the higher the accuracy. But A1 or AMH, that's very high, has started to be used to help diagnose PCOS as well.
That's amazing. Thank you. I think this list is going to be so valuable. I only have 2 questions that I took from my community, so most of these were...
Sorry. And you're looking for LH to FSH reversal. So FSH should be higher than LH. So if LH is especially 1.5 to 3 times higher than FSH, that's wrong. That's backwards. And so that shows that you're very severe, kind of in a really bad place with your PCOS.
Okay, that's actually really useful to know how to interpret these blood test results, because I'll tell you one thing. Most of the doctors, the amount of tests that you prescribed, they wouldn't do it. They'd be like, why do you need so many? It's so expensive. It's not needed. That's the worst thing, is not needed. So,
I was criticized in my training because I did that, but I just did it.
Just do it and apologize later.
Oh yeah, what's cheaper? Getting those blood tests, being on top of it, preventing diabetes, going to lead to millions of dollars over the years, or sleep apnea, or heart disease. Or all the complications of pregnancy, right? It's just, that's so crazy to say, you can't, $200 of testing, or whatever it is, and prevent all these horrible diseases, not to mention, like, the woman is worth it. Like, these are legitimate issues.
So true.
Not worth it. Who are you to say that? And why are you need to defend yourself as to why you're telling me it's not worth it. Because I have good reasons as to why it is.
That's very true. Yeah, that's
ultrasound also to consider around that time too can be very helpful. I did leave that out.
Oh, that's great. That's a great add-on. Thank you for this amazingly comprehensive list of tests. I'm sure that many women are already like taking notes and saying, okay, I need to do this, and this, and I need to defend myself. And I'm gonna say,
you know what? It's gonna be better. Just go to your primary care. They're gonna be more likely to listen to you and do it than an OB/GYN sometimes. Sorry to say that, but
in at least in the UK, I can speak for the UK, the GP won't be doing all those tests. So most of people would just go through their private health insurance, or they would pay for themselves for the tests, because if you choose to do it through your GP in the UK, they would put you on they would do some of the tests, like maybe half of those, and then you'd stay on a waiting list. I stayed 6 months to wait for a scan for my 17 centimeters ovary cyst. And I had to wait for that long to be able to get that time in which the cyst grew from 4 centimeters to, it was a dermoid cyst. So it grew like extremely fast during 6 months. And yeah, it's the waiting time that it's horrible for a lot of people.
Oh my God.
Yeah, well, at least now we know the test to do, which is going to be extremely helpful. So thank you so much for that. I would like to ask you 2 more questions, and these are questions directly from my audience, and you can feel free to answer very succinctly, because or as elaborate as you'd like. But I'm going to quote my community directly. So Sarah is asking if PCOS can be reversed truly, because we hear so many stories, and wondering if it's a case of just keeping it under control, or it's actually something that can be reversed.
Right. Yeah, I know. There was a viral video that said the word reverse, and I thought, well, what does that mean? You know, I mean, reverse. Yeah, I mean, I guess it kind of implies cure, right?
Yeah.
And no, PCOS cannot be cured. We can come close to managing it so well that it feels close to as if it were cured. But no, I mean, women with PCOS will always carry risk factors. And we very much minimize those risks and minimize the symptoms, absolutely. So it can be well managed.
Mm-hmm. That's really good to know. You can have a good quality of life if you understand the type of PCOS that you have and manage your symptoms accordingly. That's great to know. And
you know the flavor of PCOS that you have. You need to know what your labs are saying. You need to know how your vitamin D status, thyroid status, you know, and especially insulin and blood sugar status.
Yeah, and I guess it's worth saying perhaps there's different types of PCOS, so people know what to look out for.
Yeah, and one thing that women can do, let's say if they're waiting 6 months, they don't have easy access. I mean, anyone should be able to get a glucometer off the internet or at a local pharmacy and check fasting blood sugar, checked an hour after a meal. Fasting should be less than 90, and then each meal should be less than 140 1 hour after. And you can do that yourself and be proactive, and that alone will help.
That's wonderful to hear. I'm guessing Sarah is going to be very pleased to hear that as well. And Denise is asking, I'm losing weight with PCOS, feeling great, but still getting symptoms of hair growth on neck and chin, but my GP says there's nothing that can be done about my hair symptoms. Is my PCOS okay, or is there something still going on there that I should know about?
Yeah, unfortunately, once we've had testosterone for a while, you can prevent the hair growth from getting worse and thick, but once it hits that follicular change of how the follicles are developing, it's rare to reverse that. So unfortunately, yes, you have to do like electrolysis or some kind of hair treatment to manage that, especially, you know, if you want more permanent type of results. But managing and seeing all the other symptoms get better is going to help prevent any more worsening of that. But yeah, I mean, there's some thought that some supplements might help. But of course, we don't have enough data to be like, oh, for sure, this one will help. But obviously, targeting your labs and your symptoms and doing supplements, I think, I mean, you know, it's worth a try. But not to have your hopes up that, okay, there's a miracle cure for this. Unfortunately, there's not. That's the one thing that is very frustrating and difficult about PCOS and that's why it's so important to be proactive. Let's prevent that from happening. It's much easier to prevent it than manage it once it's happened.
Yeah.
For that specific symptom, most of the other things are very manageable. But yeah, it's just so hard to have that as a woman.
Mm-hmm.
So knowing, hey, you have to unfortunately focus on, you know, more permanent hair removal therapy treatments is going to get you the quickest yield.
Perfect. I think this is going to be very helpful because she might be ovulating, her PCOS might be under control, but she might still get the hair growth. So in this case, her GP was right. That is something that sticks with you, right?
Mm. Yeah, unfortunately.
Well, I think this was so amazingly helpful, Naomi. Thank you so much for this conversation, packed with value. As someone who's been through dozens of doctors trying to understand my symptoms, I think I'm one of the best placed people to say that we need more providers like yourself to look at the root cause and actually teach people the knowledge, because I think that's so underestimated how valuable it is for people to know the knowledge about their bodies, and your work is so important in that aspect and many more, and we're truly lucky to have had you here speaking to us today.
Oh, thank you. It's such a pleasure to speak with you.
Tell us, where can people find you online? Because I'm sure that they're going to be like, okay, I need to follow this unicorn doctor that really treats the root cause.
Yeah, you can find me on Instagram at NaPro Fertility Surgeon, or I have a website, NaomiWhittaker.com. It links to a lot of other resources, educational resources, including a nonprofit called RM Academy that's really focused on hopefully educating not only women and, you know, patients, but also hopefully other healthcare professionals to kind of show them that there is a wider toolkit available to them.
That's amazing. So that's NaPro Fertility Surgeon on Instagram and NaomiWhittakerMD.com. I will link the resources in the bio of the podcast episode, and you can find Naomi there. Thank you so much, Naomi. It was a pleasure having you.
It's a pleasure. Thank you.